Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello and welcome to this episode of Talking Meds. I'm your host, Jonathan Underhill. I'm delighted to be joined today by Philip Newland-Jones. Philip is a consultant pharmacist in diabetes and endocrinology and is the clinical director of the Diabetes and Endocrine Services at University Hospitals in Southampton. And we're going to be talking about the management of obesity today. Quite a controversial subject. There is a new NICE guideline that was published at the start of this year. There's been lots of publicity about the use of the various medicines that are available for weight loss. And I thought it would be interesting and useful to you guys to hear from Philip, who is very much an expert in this area. He's the lead pharmacist for NHS England Diabetes and Endocrine Clinical Reference Group as well, so has experience of this, not only at a local level, but at a national level as well. So Philip, welcome. Thank you for joining us. Just in terms of your background, what was that made you want to become a specialist pharmacist in endocrine and diabetes and latterly, I guess, obesity?
Yeah, I think, and it's in that, partly that order. So to start with, I started out in diabetes around 2010. I had the opportunity working in the hospital to see that we could really have an impact on length of stay, and it ended up at the time becoming slightly more complicated around that time. So there's a few more medicines coming out. It was an interesting area, and I find interesting from the fact that you're treating something that you can see the result of your treatment almost immediately. So there's something quite beautiful about diabetes generally. I really enjoy that. And then after I've been doing that for a number of years and became more embedded within the Diabetes and Endocrine Service, I took on some endocrine work and started off with doing thyroid and broached out into some other general endocrine clinics, and have been running a clinic in that since 2015. And then I guess as that's gone on, obesity doesn't necessarily sit in an exact site within services. So in some areas of the country, it sits within chemical pathology. Some areas of the country, it sits in its own right, and there's a completely separate standalone service within sometimes private healthcare. But for the majority of services, and certainly when we had our Getting It Right First Time, our GIRFT meetings, a lot of obesity services were linked to endocrinology. And I think historically, there's a lot of endocrine conditions that will increase the risk of obesity. So we're quite familiar with dealing with that. And likewise, we've had a lot of patients that develop type 2 diabetes who obviously have a comorbidity of obesity. So over the last sort of 10 years or so, I think quite a lot of endocrine services have badged on obesity into their kind of ongoing services. And so with regards to pharmacists around the country we've got medicines being able to actually be utilized, effective medicines that are able to be utilized for obesity. A lot of the pharmacists around the country who do diabetes and endocrine, whether that be in an ICB or a hospital setting, have had obesity kind of just pinned on to their job titles, or the expectation is they'll pick this up. And I think it's probably because the initial medicines that we're using have been very familiar to people working in diabetes for the last 10 to 15 years. If you think back, exenatide was 2007 when it was released. So we've got kind of a breadth and a long length of time of experience of using incretin therapy, which is now becoming the mainstay of treatment in obesity. So that's how I've ended up in obesity, is that I suppose it's just linked to the medicines I was familiar with.
Yeah, it's an interesting one, isn't it? I agree with you about the obesity. Where does it fit? Which BNF chapter does it fit in? And it's endocrine. It's also cardiovascular disease, of course, as well. And it's also potentially, because of the behavioral aspects associated with it, there is a mental health component there as well. People's relationship with food and their own psychological well-being. There's always a psychological component to anyone who has problems with their weight. So I think you're right. It's almost a generalist approach to the management of obesity that you need. I don't think you can pigeonhole it as being endocrine only, because there are so many other facets to it. On that, I mean, there are many people who are quite skeptical and perhaps even cynical about the management of obesity, and that it's just a lifestyle thing. Why don't you just lose weight, move more, eat a little less? It's really easy. Why don't you just get on? Why do we need to medicalize it? Why do we need to use medicines to manage that? I mean, what would you say to that?
Yeah, so it's a really, really fascinating area. There'll be plenty of people listening to this podcast who still sit there and go, actually, obesity is not a disease, and they're often people who are lucky enough not to be overweight in reality. And we'll all have friends that eat exactly the same as you and are slender. It's, and you kind of think, what are they doing that's extra or different? So the UK still doesn't technically classify obesity as a disease specifically. Even the NICE guideline that's updated describes it as a condition rather than a disease. There are quite a lot of areas of Europe and across the globe that have formally recognized over the last 50 years at different stages obesity as a chronic disease. But when you kind of look at the definition from the World Health Organization that kind of considers whether something is classified as a disease or not, a non-communicable disease, they talk about the long duration, the combination of genetic and physiological, environmental and behavioral factors that's often relapsing, remitting. And I think obesity fits perfectly into that classification. And, a lot of our bodies, the Royal College of Physicians, along with a number of other bodies across the UK will recognize, so they recognize obesity as a disease, and they will describe it as such, but actually it's not officially in our kind of literature saying it's an official. So I want to kind of pick up on some of those things briefly. We had you're right in what you've said, in that actually the answer is eat less, move more. And everything that we do that works for obesity is essentially playing on that factor. The end product of what we do is eating less and moving more, and often a combination of both. The ability for people to do that is very difficult, and I think it's different in different situations. So there's a reason why everyone will ask what's the best diet, and you go, well, there is no best diet, it's whatever works for the person. And actually, when you look at it, every diet works. Everyone can lose weight. It's just they can't sustain it. They don't keep it off for long. People lose weight and it rebounds. And your body, when you measure all of the kind of hunger hormones, the off switches for hunger and the on switches for hunger, your body counteracts any weight loss. The faster you lose it, the bigger the change in the hormones that drive your hunger. And it's really difficult to change your ability to do anything about those hormones. It's the reason why people with cancers, it affects your ghrelin, your hunger hormone. And no matter how much you tell that person to eat, they're not going to eat. They're going to continue to lose weight, even though they know they need to. So I think there's more of a part to play in hunger. And obviously, your gut as an endocrine hormone, as an endocrine organ. So your bowels and your gut produce so many hormones that are reliable or responsible for hunger and the way that you sort of metabolize calories and other bits and pieces. So I think that's the first thing, is to recognize that it's difficult. And even the best will in the world with really close support. So you go back to the 1970s and our first very low calorie diets, even then proved that people could lose weight. But by year 5, so 4 years without being followed up, everyone will regain the weight pretty much. And you only have to look at our recent 5-year data on the DIRECT study. So everyone would have heard the year 1 and year 2 data for the very low calorie diets because they were great. And they showed once again that by giving 800 calories a day, you can be successful in losing weight. But year 5 data, about 80% of people are back to the weight they were before. It is once again, everyone has rebounded on their weight, and often quite a few of those that were put into remission have now, the largest proportion of patients have now redeveloped type 2 diabetes. So I think there is more to be said than it's just your free will to be able to keep the weight off. We have to try and figure out ways to support that, and that's a combination of environmental, social, and now we've got the ability to. I think healthcare has a place, and medications and surgery and psychological support.
Yeah, I think that's fascinating, Phil. and you're right as well. It's that behavioral change aspect of that that's fundamental to anything. If you sustain your lifestyle modification, then you're more likely to sustain that weight loss in the longer term, aren't you? And that's why all these services that we're going to be talking about in a minute all come with a wraparound service, don't they? That includes behavioral, psychological, dietary, exercise, all those sorts of, all the studies that we're going to be talking about in terms of the weight management medicines have been accompanied by those wraparound services and that psychological behavioral aspect of that. I think, and I do agree with you. I think obesity is it's as much a disease, or you could make a coherent argument that hypertension is a lifestyle disease. You could make a coherent argument that diabetes, type 2 diabetes is a lifestyle. You could actually make an argument for something like COPD because of the association with smoking, or osteoarthritis because it's more prevalent in people who don't exercise as much or who are overweight or obese, or even certain cancers. So I don't think it's as easy to say, this is just a lifestyle component. We shouldn't be managing it in the way that we do with these other things that we manage routinely. I mean, you wouldn't say to someone who had really high blood pressure and hypertension, oh, you just need to manage this by reducing your salt intake and doing a bit more exercise. We would treat them with antihypertensives. So I guess that brings us nicely onto what the challenges are around the management of obesity. I mean, we've talked about this a little bit in terms of the psychological aspects of it, but what do you see as being the greatest challenges around this?
So one of the things you've just almost touched completely on is the fact that we, at the moment, it's still considered that all of what I look at as sequelae of obesity as a disease, so whether it be hypertension, type 2 diabetes, hyperlipidemia, psychological low esteem, they're all considered as comorbidities in their own right. But actually, we know that they can be treated and disappear as a symptom or a sequelae when obesity is treated. And that's a really fascinating thing. Even in all the guidance that you'll read from the NICE guidance and access to medications, it talks about comorbidities rather than, sequelae or symptoms of a disease, which is obesity. Low testosterone, menstrual irregularities, so much comes into it that it makes it really complicated, and it filters into every specialty. So every specialty has a sub cohort of patients where obesity is impacting on the drive in the increase in demand of that specialty. And as you say, this with the psychological component, is certainly for those that get to BMIs of above 40, there's a huge psychological component of that. Whether you classify it as an eating disorder or disordered eating is a different matter, but it is not a normal behavior or a normal relationship with food. In terms of, I think that's the first point, which is the complexities and the number of comorbidities this links into. In terms of the volume of patients that meet a lot of the criteria that we're going to discuss, both for medication or intervention, every specialty would think that their subgroup of patients is the most deserving and should be in the earlier cohorts for treatment. But we would bankrupt the NHS if you tried to treat even 1/5 or 1/10 of the patients that meet the criteria in the first 1 or 2 years. So I think it's trying to recognize that the savings that we'll need to make from some of these interventions will need to be bore out in the first couple of years to allow us to invest further in some of these interventions for those where the sequelae or the complications of their underlying comorbidities takes effect much later. And that's, I think, where the challenge is going to be, is the sheer volume of people that meet the criteria for a lot of these technology appraisals that have come out for medications or for even bariatric surgery have led to inaccess and people going to buy it online, finding random suppliers, or in the case of surgery, going across abroad to Turkey and having absolutely no follow-up for their bariatric surgery and then crash landing into hospital settings with complications of that. And so people are, voting with their feet. With lack of access, they're unfortunately turning to alternative suppliers, some of which are great, some of which are not so great. And also that in itself has led a bit of a Wild West in terms of the way in which the providers of those services or products in terms of prescription medicines are also governed or overseen. I would say there's a big difference in some of the services offering medications to patients because they're voting with their feet and they're trying to find it online.
Yeah, definitely. I mean, there's lots in that. The inverse care law is one of the things that I'm obsessed with, actually, and what the inverse care law says is that those people most in need of accessing healthcare are the ones who are least likely to be able to do so. And if we're not careful, that's exactly what we'll see with obesity. If you can afford to pay for it, then you get access to it. If you can't, and there's good public health evidence that those people who are in the highest areas of deprivation or lowest income bands are the ones who actually are most troubled by things like obesity. So there's a real issue there, morally and ethically around this, I think. And you've touched on as well the private providers. I know you've done a bit of work on internet pharmacy access to some of the obesity medicines. I mean, that strikes me as being something that someone needs to get a grip on before we end up in a situation where we are causing harm to patients.
Yeah, and they're great medicines in the majority of people, and they're well tolerated. I've had a patient this week admitted to our ITU and then down who managed to get hold of this medicine legitimately via prescription and an online pharmacy with a BMI of 21. And this young girl was admitted with acute kidney injury, acute liver injury, electrolytes were in her boots through the floor, and she was in ketoacidosis. She was extremely unwell. And there's got to be a better way to mitigate or to safety check against some of these either remote or virtual models of care that's currently increasing exponentially in terms of access to, inverted commas, aesthetic type medicines. So yeah, there's something definitely about that.
So just in terms of the guidance from NICE and others, but the NICE guidance in particular, what are the key aspects of that, do you think? What's the big changes there?
So one of the biggest changes is it's now an extremely long document. So it's now 179 pages long, but it actually, I think it's really aspirational in the way that it's looked at it from the whole treatment pathway approach, so very holistic in its way it's reviewed things. It's recognized and has been modernized for I think the future delivery of what obesity services need to be, which is no longer just held in specialist services. I think it recognizes the place of both community primary care in the delivery of obesity care, whether that be it the old way of looking at tier 2, tier 3 services. It's a unique guideline in some respects in the fact that it looks at both adults and pediatrics, which I think is really important because the same aspects apply. And at the moment, for a lot of areas, for those highest risk patients and those that need the greatest need, who actually are obese in childhood, especially if they're started on medications, there's very few services that they can transition to at the moment. And actually we've got a cohort in the south of England that there's nowhere for them to go. They're the highest risk group. They're those that have required the most psychological intervention because of a lot of the social aspects of why they've gained weight in childhood as well. And at the moment, at the age of 18, they're falling off a cliff to go to nowhere, no service. There's no tier 3 service that will take them longer than 6 months. So I think looking at the whole pathway, both across from pediatrics all the way to frailty and some of the kind of symptom control that you might need in those who are elderly and overweight with heart failure, for example, in terms of quality of life, I think it really does bring in all of those aspects. It touches upon the medication aspects. It's not particularly specific, but refers to the very rapidly changing space of medications, which I think is going to take a larger chunk of of patients than we've ever seen before in obesity management. So, historically, we've had a couple of medicines. Even look 10 years ago, it was basically orlistat, and everything else after that has been shown to be dangerous or failed. Everything was withdrawn from European and American markets because they're basically amphetamines. But other than that, it was either that or surgery, which is quite extreme when you kind of think about it. And that changes people's outlook for life. They'll never eat normally again if you have, that type of bariatric surgery, which is chopping bits out. So I think it's a really useful now to see a much larger proportion of patients being offered access to potentially medicines that will have almost a greater weight loss than some of the earlier bariatric type interventions that were endoscopically, endoscopy kind of sleeves and other bits and pieces that were put in terms of endobarrier, for example. So medications are now far superior than some of those surgical treatments, which is amazing to see. It is amazing to see.
Yes, indeed, Phil. Yeah, absolutely. I was just going to say, I think props to my former colleagues at NICE here for the implementation support materials that they've done with this. I think if people haven't seen the guideline, there is a practical guide to using medicines to manage overweight and obesity that was written by my colleagues in the medicines team, and that's really quite helpful, I think, for people thinking about where does this fit in the local care pathway in terms of medicines. There are starting criteria that are well defined within the guideline, and there are stopping criteria that are well defined within the guideline as well, something we've been talking about for a long time that NICE doesn't do enough of. So we have to give credit where credit is due there. It's very clear what the stopping criteria are. I think the other thing, and talking about the numbers here in terms of the clinical effectiveness, I have to say, when I read there's a document that was produced by my mate Andy Hutchinson at the medicines team, so I'm going to give him a specific shout out here, which is the local formulary information for tirzepatide. And the summary of the two big studies, the SURMOUNT-1 and SURMOUNT-2 study, the outcome of weight reduction of 20% or more at 72 weeks of tirzepatide is, in the placebo group, 3.1%, so 3 out of 100 people achieved 20% weight loss or more after 72 weeks taking placebo, and 56.7%, so 57 out of 100 had weight loss of 20% or more at 72 weeks. That, as you say, that is the sort of the results you get with bariatric surgery with tirzepatide. So I was actually quite surprised at how effective this medicine. Now, I know there's all the caveats around this is in a clinical trial situation with all the wraparound service that goes with being in a clinical trial and all the rest of it. And is that the sort of thing that we will see in the real world? And we still don't know whether that's the case. And that's something we need to look at. But just in terms of those figures, it made me sit up and think, actually, no, the service redesign that's required to deliver this, perhaps in primary care settings rather than just in tier 3 services, is something that I think we should be looking at in terms of because we're talking about the health of the nation here. A 20% reduction in weight for people will bring significant reductions in other comorbidities like type 2 diabetes, like hypertension, like heart failure, like osteoarthritis, etc. So it's a real challenge, but it's also something that I think people need to be aware of.
Yeah, I think so. That 10% used to be the kind of mark where we see a change in comorbidities in terms of the status of those. 15%, there's a couple of those, but 20%, it's then mortality. It changes the outcomes for mortality. So not directly in this trial because it's a short length of time, but actually if you look at 20% weight or over 15% weight loss in the longer term, that has an impact on mortality in those that are overweight. So I think they are slight game changers. You only got to look now where I think some of Novo Nordisk's newer products that have just reported trials that were only getting to sort of 16 or 17% weight loss. And that was seen as a failure, Loads of people disinvested from after those results. And you think 5 years ago, you would look at that, 16% weight loss is incredible from a medicine, but actually that's now a low ballpark figure for some of the newer medicines that are en route.
Yeah, and of course there are safety concerns with these medicines as well. Of course, there is MHRA warnings about looking and being vigilant for signs of pancreatitis, for example. So anyone taking this, anyone prescribing this, needs to be aware of what the signs of pancreatitis are. If someone's got a fever or they've got severe abdominal pain, then you need to let your healthcare professional know as soon as possible, and that's an important counselling point, I think, for pharmacists and other prescribers.
And I think on that note, it's worthwhile noting I get lots of questions and queries about that from usually GPs who say they've gone privately to ask for, and then they've come to ask if it's sensible afterwards. In someone with, say, for example, a history of gallstones or previous pancreatitis. And people who are overweight, especially if you've had previous gallstones, are already at risk of pancreatitis. The slight problem is some of those people who require cholecystectomies have not been able to be fit for surgery to have that electively because they're overweight. You end up this chicken and egg scenario. What do you do first? You try and treat the weight loss with a medicine that has a risk of pancreatitis, or try to get some weight off to get them to have the cholecystectomy first. It's a really difficult situation, and there's no exact way to monitor for it at the moment in terms of biomarkers that are I would say, reliable. You can check amylase, lipase, you can check your liver enzymes, but actually, unfortunately, if they're going to have pancreatitis, it does go wrong in some circumstances, and people have died. So it is not without risk, and I think that's really important. These are not medicines that we should be just able to pick up and purchase online. They do need oversight, support, and appropriate review of patients. First, in terms of their often multiple comorbidities, sometimes undiagnosed comorbidities, I'd say.
Yeah, indeed. I completely agree that this isn't something that we can just, give out or sell over the counter from garages to people or whatever. This isn't something that we can put in the water supply. It requires careful monitoring, careful shared decision making as to whether this is the appropriate option for people, because there are side effects and there are risks, and people need to be made aware of that if they're going to make that truly informed decision. I guess the other question that I've got in my head, Phil, is that what happens when you stop taking these medicines or you stop using them? Do we know yet whether weight gain comes back or what?
Yeah. So essentially, nine in 10 people will regain almost identical weights they put on within about 18 months of stopping the product. And that's been the same for all incretin products that have had the stop criteria post trials that we've seen so far. So there is the 10% proportion who, with the weight loss, change what they're doing, whether it's increasing activity or that enables them to do something, and they can keep the weight off. And to be honest, I think we need more studies looking at what about that 10% has gotten to keep the weight off the medicine, because we need to emulate that in a lot more people. But otherwise, it's the same as what happens when you lose weight. By giving these hormones, your body counteracts, which is why your weight always plateaus. So the weight will always plateau because your other hunger hormones will kind of compensate for the fact that you're giving, in some cases, 2 or 3 off switches for hunger. And in the long term, so 12 months afterwards, those hunger changes, those hormone changes in your body are still changed. So you have an increased appetite compared to what you did before. And without the effect of the medicine, people are driven to eat. Your body's telling you to try and eat more. So unless you can try and keep it off, usually with activity at that point, you'll regain the weight. Now, some of the interesting, very early studies that we've started to see is that, and I've always wondered, what dose do you need to maintain weight? So we're using these higher doses to lose weight, but actually, is there something in being able to give a much lower dose for weight maintenance in the longer term? Even switching to a cheaper biosimilar, for example, is not particularly good anymore at weight loss, but actually, in terms of taking the edge off weight gain and suppressing some of those counter-regulatory mechanisms, is there something about that? Can we be more cost effective for weight maintenance by using low doses in the long term after people have lost weight? And I think there is much work to be done about that going forwards. We do it in a lot of our pediatric cohorts that, historically off license, we would use Ozempic for. And then when they get the weight off, we would go to the lowest effective dose at suppressing appetite, and it works. But we need some trial evidence to prove that's a really good concept. That at the moment, there'll be no pharma companies that probably want to look at that, I suspect, unless you got someone bold, because it's not going to make them money, but there's something in it. Definitely.
Yeah, definitely. I mean, again, this is the picture I have in my head is somebody who is severely overweight or obese, and because of that has stopped exercising because maybe they've got joint pain or they get embarrassed going to the swimming pool or whatever, and it's stopped them doing that. If that initial weight loss can then enable them or re-enable them to go back to their previous, swimming or exercise or walking the dog, then that's potentially more likely to be sustained in the longer term. Again, that might just be my weird way of thinking about it, but it might be that 10% of people that you're talking about. That's who in whom these interventions are most effective. And I agree with you. That needs a good look at by the research community to find out exactly, is there something in particular about that 10% of people who are sustaining their weight loss in the longer term that we need to, as you say, capture in others. Just to finish off, Phil, it'd be worthwhile looking towards the future of this as well. So future treatments that might come out, maybe with different mechanisms or similar mechanisms, but in a perhaps with fewer side effects or etc. And also, I think in terms of the weight, the broader provision of weight management services and what that might look like. We've already said that there is potential for community pharmacy or primary care to be involved in weight management service delivery. So those two things. So future therapies and what does the future provision of service look like?
Yeah, so I think there's a couple of aspects. So we've seen from the difference between the just giving GLP-1 versus giving two incretin hormones together. So in the case of tirzepatide, so that's GLP and GIP, that you get this augmentation of giving two off switches for hunger. And that's why you've got so much more weight loss in particular from tirzepatide compared to all previous GLP-1 products on their own. So, whether you look at Wegovy or Saxenda, tirzepatide is far superior by giving two agonists rather than one. And I think that there's something in that. So there are some products where they add in three agonists together. So retatrutide is en route, which is also a glucagon agonist as well as GLP and GIP. And that is looking at more than 50% of people getting 25% weight loss. So we're looking at a quarter of body weight. And that's probably the kind of market leader in terms of phase of trials at the moment. But there are also some other interesting products en route, both for diabetes and for obesity, that are incretin or GLP-1 receptor agonists that aren't analogs. So these are medicines that are oral, simple molecules, not peptides. So not the same as oral semaglutide, which is essentially an oral peptide that's tried to get as much absorption as possible. This is a simple, easy to kind of manufacture tablet that is getting as much weight loss as some of the other big hitters of the once a week injection. So we are very close to once a day tablets that have no problems with binding or taken with food that can cause sort of 16 to 18% body weight reduction across 72 weeks. So I think that for access and for cost, I suspect, because I can't imagine they would be the same cost to manufacture, but also the ability to kind of have that as a generic medicine in the future. And there's more than one of them coming. So they're called the Gliprons. So orforglipron is one of the first ones en route. So that is, I would suspect, will be probably a game changer for the market because it makes access a lot easier. And then one of the kind of downsides for weight loss is you essentially end up losing a lot of lean mass as part of weight loss. So, you lose 20% of your body weight, and at least 30 to 40% of that 20% is going to be lean muscle mass. And so there's a concern that actually we're making people frail before their time. They'll end up sarcopenic. So there are some very interesting combination products, probably they are in early trials at the moment, that are myostatin inhibitors. So these are medicines that companies already have that are used for sarcopenia or muscle wastage conditions that stop the breakdown of muscle. And the same companies also have some weight loss medicines, and they're obviously trialing the combination of two together. What happens if you give a very potent weight loss medicine with an anabolic medicine, essentially a myostatin inhibitor, in combination to see if you can keep lean muscle mass and lose fat mass? And I think that's a fascinating area going forwards, which is probably the most interesting angle of investigation from here on, I suspect. So yeah, watch for the future.
I was going to say, watch this space. It sounds very, very interesting and probably challenging for the health service as well.
So every company has got something coming. There's not just our current players. Everyone has recognised the market space is enormous, and there's a lot of slices of pies to be had. So there's going to be a lot arriving. The other side of that is, in terms of your question, you'd asked about what was the future for the services. And I think to start with, you'll recognise that everyone listening will recognise there's areas of the country that have really good provision of obesity service, and there's areas of the country that definitely don't. And so at the moment, I think there will be a focus on trying to get the highest risk patients seen in the first couple of years, especially for tirzepatide, where the focus will be looking on those probably with sleep apnea, intracranial hypertension, something that also gives quite a quick return on investment. So you can come off CPAP, you can end up not being hospitalized with intracranial hypertension and off a lot of medicine. So even with type 2 diabetes fitting into that, a large proportion of the first cohort of patients that the tirzepatide TA is looking at, so BMI 40 with 4 weight-related comorbidities or sequelae, a lot of those will have type 2 diabetes in reality, so would probably benefit from the diabetes as well as obesity perspective. So I think a lot of those, the focus will be, they will be the most complex patients, and therefore they really probably also need the psychological and wraparound support that's required from specialist services. But further down the line, there'll be plenty of other people who aren't quite as severe, don't have quite as many comorbidities, that also require access. And that's where we're going to need a lot more help. There's no way that specialist services are going to be able to own this on their own for the future. This will have to be done as part of standard of care in both general practice and across community care. So whether that is a model, so NHS England essentially asked whether that, they gave 7 examples of what was possible models of care to deliver obesity medicines in the future. And that includes digital providers with that kind of hub and spoke dispensing model, but there would need to be definitely some safety perspectives from my side built into that. Also the idea of maybe running community pharmacy hubs that would do it. So those pharmacies that are taking on more appropriate face-to-face services. And that, I think, really plays into some of those and equity of access, as you discussed, those that have the lowest social deprivation, highest social deprivation will be those that are the most obese, and also those that have the lowest qualifications in terms of education are those that have the most obesity. So we need to make sure that we're providing access both for those at the heart of those communities, rather than asking them to jump through loads of hoops. And likewise, that also extends to mental health institutions, prisons, anywhere you can think that actually there's a lot of patients that fit the criteria that are not going to get immediate access.
No, I think that's a really, really good point. Adam Todd's work up in the University of Newcastle's looked at community pharmacies are exactly situated where those areas of deprivation are. So using community pharmacies for this would seem like a good way of sort of addressing that inverse care law and the potential issues for that. Phil, thank you so much. That's been an absolutely fascinating discussion. Hopefully listeners have found that useful. We'll put some links in the show notes to some of the documents that we talk about. Obviously, the interim commissioning guide is out for tirzepatide now from NHS England. I'll put that in the show notes as well. That's worth a look at and a read if you're interested in that service. But thank you so much, Philip. It's been an absolute pleasure. Cheers.
Likewise. Thank you very much.